Hey guys, today we're going to talk about IV cardiac medications. This is going to be part one of part two, and the first few medications that we're going to talk about are antiarrhythmics. So if you need to go back and review that video, go ahead and do so. Our first medication is amiodarone. Amiodarone is a class 3 antiarrhythmic or a potassium channel blocker. It also has some class 1, 2, 4, and alpha 1 antagonist properties, but we're going to focus on its class 3. Amiodarone is for the treatment of VFib and VTach, and it's going to work on our non-nodal action potential. And if we remember with our antiarrhythmics, we're trying to affect this area under the curve, because this area under the curve relates to the refractory period. So no other conductions can happen during this time. Class 3 antiarrhythmics are going to affect phase 3 of our non-nodal action potential. So we're going to end up pushing out or delaying our phase 3. So our curve is going to end up transforming to be looking more like this. And this is going to increase our refractory period and hopefully slowing down our heart rate. The dose for amiodarone comes in two styles. Our patients without a pulse, or our cardiac arrest patients, our first dose will be 300 milligrams, followed by our second dose being 150. Our patients with the pulse will give 150 milligrams in a drip over 10 minutes. Our next medication is going to be diltiazem. Diltiazem is a class 4 antiarrhythmic or a calcium channel blocker. And this is going to be for the treatment of SVTs, so that narrow complex tachycardia, but specifically AFib and a flutter. Diltiazem works on nodal cells, so SA and AV node, and it's going to decrease the rate of SA node firing and decrease AV conduction. And it's going to do this by affecting our phase 0. And just like amiodarone, it's going to delay that phase or push out that phase, and we're going to increase our area under the curve and get a shape more like that. And by increasing this area, we're increasing the refractory period and slowing down our heart rate. The dose for this is 0.25 milligrams per kilograms, given slowly over 2 minutes. Our third medication is metoprolol. Metoprolol is also an antiarrhythmic. It's a class 2 or a beta blocker. Uh, so beta blockers are going to affect our autonomic nervous system. And if we remember, our autonomic nervous system is uh, broken up into our sympathetic nervous system and our parasympathetic nervous system. And metoprolol is going to be for the treatment of SVTs as well, especially those AFib and flutter. And it's going to do this by affecting the beta 1 receptors in our sympathetic nervous system, or that stress response. So by blocking these, we'll decrease our sympathetic nervous response, which will increase our parasympathetic, and with the result of decreasing our heart rate and AV conduction. The dose for this is 5 milligrams given very slowly over 5 minutes. Our next medication also works on the autonomic nervous system, which is atropine. Atropine is an anticholinergic. And it's going to be for the treatment of bradycardic rhythms. So atropine, like I said, is going to affect our autonomic nervous system, but instead of impacting our sympathetic nervous system, we're going to block or slow down our parasympathetic nervous system. So atropine is going to come over and block the muscarinic receptors in our parasympathetic nervous system and reducing that response, which will allow for an increased sympathetic response and increasing our heart rate. You can kind of think of this as taking the foot off the brake. The dose for this is 0.5 milligrams. Our next medication is adenosine. Now, adenosine is an antiarrhythmic, but doesn't really fit into the 4 classes of the Vaughan-Williams. You could kind of consider it a class 5, or basically an other. And this is going to be for the treatment of SVTs, or that narrow complex tachycardias. Now, adenosine is a naturally occurring nucleoside. And because of that, it has receptors. So what adenosine is going to do when it stimulates those receptors on the cardiac cells, adenosine is going to come over, and that's going to result in a decrease in electrical conduction, it's also going to have a decrease in SA node activity or automaticity. But more importantly, it's going to have an increase in AV node refractory period, which is going to kind of cause an AV block. And this AV block will hopefully give us a pause in this rapid cycle that we're having of this SVT. And if we can get this to pause. Hopefully we can get this cycle to stop, and then we can have a return to a regular sinus rhythm. Now the dose for this is the first dose being 6 milligrams followed by 12 milligrams. But adenosine has a very short half-life, so this needs to be a rapid IV push. Our last medication that we're going to talk about is magnesium sulfate. Now, magnesium is an electrolyte that plays a role in the transport of sodium, potassium, and calcium. And we're going to use this for the treatment of torsades. Now the thing about torsades has most of these patients, in order to kind of lay down the foundation for torsades, a lot of these patients are going to have long QT. And this can be drug-induced or medication-induced or genetic. But the problem is a lot of our antiarrhythmics cause long QT. So we don't want to add to it. So we're going to use magnesium sulfate. And what magnesium sulfate does is it goes over to our calcium channels. And calcium plays an important role as kind of the person or the thing that will tell the cardiac cells when to start and stop constricting. So calcium is going to come into the cell and do that. But magnesium is going to come over and attach itself. And what magnesium is going to do is slow down that influx of calcium and reducing that signal or decreasing that signal. It won't be as strong. And this will hopefully slow down our heart rate. The dose for this is going to be 1 to 2 grams. And because it's an electrolyte, it needs to be given very slowly. So we want to give this up to 10 minutes, up to over 10 minutes. So that's what I have for you for today. If you have any questions, please let me know. Thanks.